morning. Thank you very much, Mr. Chairman. Thank you again to the Scientific Organizing Committee for inviting me once again. I have no conflict of interest to disclose. Partial breast irradiation, right, is a controversial issue. There is several data that are coming. All the trial underlines some common principle. The first one is that whole breast irradiation is not always necessary, since multicentric cancer foci remain dormant and are not generally responsible for ipsilateral breast recurrences. The second point in the majority of the studies that most of the local failure occur in the vicinity of the primary tumor, more than 85% in the majority of the trial occurred in the scar area. Partial breast irradiation is a concept, and if you like to apply this concept in clinical use, you can perform with different techniques or modalities. Some of them are not invasive, LINAC-based, 3D conformal irradiation or mixed beam, EMRT, helical EMRT, that means tomotherapy, stereotactic irradiation, sometimes with cyberknife, some limited experience with the protons on special device. There are a lot of other treatment modalities that we consider invasive, mainly based on the brachytherapy approach and IRT, intraoperative approach. The most common use is interstitial brachytherapy, both with low dose rate or high dose rate. Some modalities include intracavity therapies like intrabeam machine, orthovoltage, 50 keV, intraoperative electrons, mainly with mobile LINAC, mammocide, the special balloon, soft, and some limited experience with the use of permanent seed implant, iodine, on the nuclear medicine technique like avenidation. You can see here a summary of randomized trial. Some of them are still ongoing, some are already published. What is clear that in this trial different technique has been used, and there are a lot of different in the schedule, both from the number of fraction. The range is from 1 to 15. We are in the frame of hyperfractionation, but it's really different. One single shot with respect to 3 weeks of treatment. In the time, as I said, from 1 day, or if you prefer in 1 minute, to 3 weeks. The dose, the total dose range from the 20 to 40 gray. And if you apply the model that has been already shown by Dr. Harris, the BED, the biological effective dose, if you use the value of alpha beta 4, that can be predictive for tumor control, the range is very wide, from 42 to 88 gray. And if you use alpha beta value of 10, the range is from 37 to 54 gray. So that means it's not easy to compare the result of this trial. Different in the schedule are not the only. We have also difference in the interval between surgery and partial breast irradiation that can range from minutes in case of intraoperative approach to some days if you use brachytherapy, interstitial brachytherapy, or some weeks if you use technique with external beam irradiation. Sometimes if the patient has to receive chemotherapy, several weeks of treatment. It's also different, the treated volume, that is very small in the case of orthovoltage, the TARGIT trial, and is larger, but not the same, using electrons, interstitial brachytherapy, or again, LINAC-based technique. Also, it's really important to define, in this case, more than in whole breast irradiation, to have a good definition of the clinical target volume. And also the quality of the trial can depend on the use of different methods like clips or, like in this case, the co-registration between CT and MRI images. In spite of this very important difference between among the various clinical trials, the results at the end are not so far. You can see here some of the trial. The most mature trial is the trial from Budapest for Dr. Polgar, with recently updated with a follow-up of about 10 here. You can see that the local control, the local failure rate is 5.5%, is approximately the same that our randomized trial, ELIOT, 5.3%, 6% in our series out trial with the same follow-up, 5 here. Slightly less the local failure rate in the TARGIT trial and the Mammocyte registry, 3.3 and 3.8, but this may depend also from the shorter time of follow-up in these two reports. 5% means one local failure per year in terms of rate. And if you look in the literature and we look in the periodical report of trialist group, we can see that this rate is more than acceptable because in case of breast conserving surgery plus whole breast irradiation, the local rate at 5 years in case of patient with negative node is 6.7% at 5 years. That increase at 10% at 8 years. And in case of patient with positive node is 11% at 5 years and 13.2% at 10 years. That means more than the current local failure rate in partial breast irradiation studies. And also, if we look our rate of local failure in our randomized trial that will be published soon, and also in series of out trial that has been already published, we can see that there are no big difference with respect to historical traditional experience in Milano with the study, Milan 1, Milan 2, and Milan 3 study. 5.3 and 6% is compared with about 4% in the previous study with whole breast irradiation. As I said before, we have one mature study with a follow-up of 10 years. Unfortunately, this trial is quite small trial. Trials come from National Institute of Oncology and compare the tumor bed alone treatment, mainly using high-dose ray brachytherapy, versus conventional whole breast irradiation. There is a strict selection of the patient for the accrual, patient age 40 years or more, unifocal disease, no more than 2 centimeters in maximum diameter of the tumor, clear margin, negative axilla, only micrometastases are admitted, only histological grade 1 and 2, excluded grade 3, and obviously the patient have to be suitable for implant. The result, as I said, has been recently updated, and you can see that there are no statistical difference between the treatment of the tumor bed alone, partial breast irradiation, 5.5% with 7 negative events, versus 4.6% with 6 negative events in terms of ipsilateral breast recurrences. We have approximately also the same rate, 2.4 versus 3.1 in terms of true recurrences or marginal miss, and we have about the double of elsewhere, that means the other quadrant is the same breast, 3.1 with respect to 1.5 in obviously in the arm of partial breast irradiation. But again, if we look in the literature, we can find that using whole breast irradiation after breast conserving surgery, we have a decreased rate of local failure. If we consider the older study, that means around the 80, we have a range of about 10%, like in the trialist group analysis. During the 90, the range decreased from 3 to 5, 6% at the maximum. And very recently has been published some result in which the rate at 5 years of local failure is no more than 1% or sometimes less. We have also checked in our institute, and in 2010 we have published a series of about 3,000 patients treated with whole breast irradiation. We normally use the boost after the 50 gray on the whole breast, treated between 2000 and 2003. And we observed at 5 years of follow-up a local failure rate of 1.1%. So that means that today it's very difficult to accept 1% per year of local failure. You have already seen other trial. One of the already published is the TARGIT trial, very huge trial, 2,200 patients enrolled in different institutions in 9 countries. Comparison between IRT with KV system, ortho voltage, 20 gray at the surface of the applicator, versus conventional whole breast irradiation with or without the boost. In this trial, each center could decide that patient randomized in the arm of IRT alone, but with certain pathological findings, maybe lobular cancer, AC+, etc., can receive whole breast irradiation in addition. The result has been published 2 years ago on Lancet Oncology, and at that time there are no statistical difference between the target group, 6 negative events, 1.2% of local failure, and 5 negative events in the whole breast irradiation group, 0.95%. No statistical difference between the 2 arms, the experimental arm and the conventional arm. The result of TARGIT has been recently updated on the San Antonio Breast Cancer Conference in December the past year, and has been presented the 5-year cumulative risk with a median follow-up increased to 29 months. And you can see that the results are changed. In the TARGIT trial, the ipsilateral breast recurrence rate increased of about 3 times, 3.3%, and remained quite stable or increased less. The rate of failure in the conventional arm, and from 1% is now 1.3%. This means that there is a statistical difference in favor of whole breast irradiation in this trial. In addition, we have to point out that this is an intention to treatment study, that some of the patients, about 15%, received, in addition to the IRT approach, also external beam irradiation. And according to the stratification in different categories of risk, over 60% of these patients are in the suitable category according to the ASTRO guideline. Now I would like to show you some experience in Milano. We have a long history in the use of IRT to perform partial breast irradiation. We started on July 99. This time was not so common, this approach. And we have different protocol. And in total, we have treated, up to the mid of the past year, 7,781 patients. The great majority with IRT alone, ELIOT alone, a single shot of 21 gray, 4,700 patients. We are using for younger patients ELIOT as a boost, 12 grade in this case, followed by a short course of accelerated whole breast irradiation, about 1,000 patients. And also we are applying this technique with a dose of 16 gray after the procedure of nipple-sparing mastectomy, more than 2,000 patients treated in this period. This is the flowchart of the study, about 650 patients for each arm. We did not observe any difference in terms of survival, 5 and 10 years, but we observed a significant difference in terms of local relapse rate in favor of the external beam irradiation. You can see here the detail, 5.3%, as already mentioned, versus only 0.7% in the external beam arm. That means that we expected less in both the arm, but much, much less than expected in the arm with conventional treatment. And we did not observe any negative event in the ipsilateral breast cancer, that means in the other quadrant, elsewhere recurrences in the arm with conventional treatment. 2.1 in the other one, in the ELIOT arm, plus 3.2% of true local relapse. It's clear that the main problem in order to continue to apply partial breast irradiation is the proper selection of the patient. So we have to identify patient suitable, really suitable for this kind of therapy. There was some recommendation in the literature, both from ASTRO and ASTRO Society. They tried to identify low-risk group that they stated can be treated or could be treated outside the clinical trial. You know this table very well. Normally a patient, according to the ASTRO statement, more than 60, with tumor no more than 2 centimeters in maximum diameter, and with estrogen receptor status positive. You can see that the majority of the criteria in order to establish a different category of risk is depending from the factor of the patient, like age, for example, or from pathology, tumor size, T-stage, margin, grade, etc. And there are no other markers that can be used in order to identify properly, as I said, the category of patient. The same concept has been applied in the ASTRO recommendation with small difference, younger patient, age more than 50, tumor size up to 3 centimeters, and no difference in terms of status of estrogen receptor. We try to look to understand in our series, on out trial series, 1,822 patients. We have published it on the Red Journal, this paper, in which stratifying according to the ASTRO category, you can see that in the group of suitable, we have only 1.5% at 5 years of local failure, increased to 4.4 in the intermediate group, and double 8.8 in the unsuitable group. But what is also important that we observed extremely low rate of local failure in patient, always stratified, but patient with luminal A tumor, no more than 2% in all groups, but patient with luminal B tumor in the unsuitable group, the rate increased up to more than 11%, patient with positive HER2 up to 16%, and patient with triple negative set up to 17%. So that means the importance of other markers in order to define the right indication. The same is according to the stratification, according to the ASTRO categories. Also, we have published it on the Green Journal. Again, 1.1% in the good candidates to PBI, increased to 7% and 8% in the possible intermediate group and contraindicated group. And again, luminal A tumor, very low rate of failure, that increase in luminal B up to 9%, in HER2 positive patient up to 18%, and again 18% in patient with triple negative disease. There are few reports, my best knowledge, only one, about the role of this subset, biological subset, in order to indicate partial breast irradiation. There is this study from Boston, recently published, in which they found in accelerated partial breast irradiation by external beam irradiation that the overall outcomes were excellent, particularly for patients with ER-positive node, ER-positive receptor, sorry. Patient with triple negative breast cancer had a significant higher ipsilateral breast recurrence rate than others, 33% versus 2% only, and obviously larger prospective 3D partial breast irradiation clinical trials should continue. What we found in our randomized trial, before I show you our trials series, The lower local relapse rate has been found in women with not palpable disease or small tumor, up to 1 centimeter in maximum diameter, but also in patients with well-differentiated tumor, with a low proliferation index, in patients with luminal height tumor, and obviously suitable for accelerated partial breast irradiation according to the ASTRO stratification. As opposite, we found the higher rate of local relapse also in the randomized trial in patients with HER2 positive or triple negative patients with more than 10% of local failure. This is the slide. There are no differences according to the ASTRO recommendation. Just to close my talk, that the proper selection of patients for PBI is the current issue for the next years. The value as prognostic factor of biological subtyping has been demonstrated mainly for distant recurrence and survival in breast cancer patients. However, this value is not still well defined for local or local regional recurrence. And the recommendation is that the subgroup of patients suitable for partial breast irradiation should be identified not only for age or tumor size, but more important, for biological subtype, estrogen receptor status, progesterone receptor status, HER2, and in the future also for the profiling of gene expression. And this emerging area of research should be included in designing new clinical trials. Thank you very much for your attention.